welcome everybody to this series that we're calling Lunch and Learn. And the purpose of it is to review with the fellows and the approaches that we use in both acid-base analysis and other fluid and electrolyte disorders. So last week we reviewed just sort of the simple blood chemistry that one needs to think about without getting into anything clinical. And I thought I would just, for those that weren't there, review some of the highlights. So and these slides are available for those that are interested. Last week, we reviewed the bicarbonate buffer system as shown on top, showing all the species that are in equilibrium in your blood. We defined the total CO2, which is what you get back when you get the chemistries back from the blood. Unfortunately, people still call that bicarbonate or CO2, but it's not. It's called the total CO2 because it represents all the carbonated species in blood, which include bicarbonate, carbonate, carbonic acid, and dissolved carbon dioxide. And as we talked about last week, it's mostly bicarbonate. And that's why people sometimes confuse it. We also talked about the short form of the Henderson-Hasselbalch equation, which is something that was derived in the 1960s by Bleich in the New England Journal of Medicine. And it states that the hydrogen ion concentration is equal to this constant times the partial pressure of carbon dioxide divided by the bicarbonate concentration. And it's nice because it's one of the few things in medicine where you can check the lab. Now, there's a caveat in that in blood gases, the hydrogen ion concentration is measured. We don't actually report it as such. It's called the pH, which is the negative log of the hydrogen ion concentration. But the point is it's measured. We also measure the PCO2 with a PCO2 electrode, and the machine calculates the bicarbonate. There's no measurement for bicarbonate. So if you just use the blood gases, it's always going to work out when you plug the numbers in from the blood gases. So in order to check the consistency of the numbers, you have to plug in 3 independently measured numbers, but there's no way to measure bicarbonate per se. So we use the total CO2 that I mentioned a minute ago as a surrogate for that. And it's not exactly equal to the bicarbonate. In fact, in respiratory acidosis, when the dissolved CO2 can increase significantly, you can get a much higher total CO2 than the bicarbonate. And then there are other artifactual situations where the total CO2 measurement is artifactually elevated in people who have certain types of hyperlipidemia, especially high triglycerides. But be that as it may, the total CO2 is usually about 1 millimole per liter higher than the bicarbonate. And we also talked about differences between arterial and venous blood. I'm just quickly going through the slides from last week. So there are male and female differences. Also, we tend to always think of a hydrogen ion concentration of 40 or a pH of 7.4, bicarbonate of 25, and a PCO2 of 40 as being the population mean numbers, but that's only true in males. If you measure these numbers in females, they're slightly lower. The pH is the same, but the PCO2 and bicarbonate, and not shown here, the total CO2 in the chem panel is also slightly lower. Then there are also differences between venous and arterial blood, but you can use venous blood gases if you're not interested in the PO2 to assess someone's acid-base disorder if you think there is one, or normality. Now, there are sometimes greater differences than you see here. What's shown is that the pH is slightly lower in venous blood, PCO2 is slightly higher, the bicarbonate is slightly higher. In a certain sense, conceptually, the venous blood has a mild respiratory acidosis because if you think of it, the cells are making carbon dioxide in the mitochondria and putting it into the blood that's flowing by them. That blood, then when it gets to the lungs, then the carbon dioxide is excreted by your lungs. And so the arterial side is going to have a slightly lower carbon dioxide concentration. And we always see this difference where it's slightly higher on the venous side because that's prior to the lungs. And so you always get a mild respiratory acidosis in the venous side. We don't call it such, it's just normality. So you just because it doesn't represent abnormal physiology. Now, there are instances where the lungs can get rid of CO2, but the blood flows past the cells very slowly, and that's when you have a low cardiac output. And in that instance, as we talked about last week, the PCO2 in the venous side can get much, much higher than it normally is from the arterial. And conceptually, you can just think about it. Let's say you have a river floating by a bunch of houses on a street, and each house is putting a car into the river or a boat, whatever it is. As the river slows down, per unit volume of that river, there's going to be more boats, right? If you just think about it, something flowing very slowly versus fast. So the same thing is true with carbon dioxide. You have this fixed input, but if the blood flow slows down, there's going to be more carbon dioxide in a given volume of blood than there would be otherwise. And so that's what you see when the cardiac output drops. And as I was saying last week, in fact, people used to use the venous versus the arterial PCO2 to assess someone's cardiac output at the bedside. You can still do it. If you really think someone's cardiac output has dropped, you should just get a venous and arterial blood gas and then subtract the PCO2. And if the answer's, not 3, but it's 6 or 7 or 8 or even higher, then it is true the patient has a low cardiac output. Now, the differences will be there as long as the ventilation is normal. Once their ventilation decreases, then they will equalize again because the arterial side will also have a high PCO2. So the assumption is that the blood is flowing slowly past the cells that are making carbon dioxide, but with the ventilation being normal, once that solution with a higher carbon dioxide concentration gets to the lungs can excrete all that extra carbon dioxide fine. So the arterial side looks essentially normal. You don't see this increased PCO2 on the venous side. And what you really are seeing is a worsening respiratory acidosis on the venous side in someone with a low cardiac output without the arterial blood changing at all. That's really conceptually what's happening. As I say, there's always a slight respiratory acidosis on the venous side. It just exacerbated when the cardiac output drops. We talked about how the lungs are responsible for keeping the PCO2 constant despite 20 moles of carbon dioxide roughly being made per day. We talked about the kidneys having to keep the bicarbonate constant. There's 2 mechanisms we talked about. One, you have to reclaim all the bicarbonate coming through the glomeruli that you have. Roughly 4.2 moles a day are filtered, and they must be reclaimed in order not to have any bicarbonate in your urine. And we know empirically there's very little bicarbonate in normal urine, so it must be absorbed because it's freely filtered. And it turns out it's roughly a box of Arm & Hammer baking soda. And if it didn't occur, your bicarbonate in your blood would be 0 in about 4 hours. We also talked about how this reclamation occurred. I won't get into it again, just to say that there's thought to be no important direct absorption of bicarbonate. It's done indirectly through proton secretion, and then the carbon dioxide that the bicarbonate is turned into coming back into the cell, reconverted into a proton and carbonate ultimately. And it's the carbonate that's transported out of the cell with sodium on a transporter called NBCE1A that we've studied for years in our lab, and actually came up with the first atomic structure of this protein, which you can read. The other important phenomena that occurs is that your diet makes protons. So if you're on an average North American diet, you're making hydrochloric and sulfuric acid. That's roughly 50 milliequivalents a day. That can't be allowed to occur per se because the protons that are being secreted will combine with systemic bicarbonate and intracellular bicarbonate, because really the protons will sop up all the bicarbonate no matter where it is ultimately. And you'll make carbon dioxide, you'll excrete that, you're fine as far as the carbon dioxide, but now you're going to have a lower bicarbonate in your blood. It's no different than having lactic acid coming in or starting a hydrochloric acid drip. It doesn't matter. The protons are coming into the blood and they will bind to bicarbonate. And if that occurred, despite the reclamation of bicarbonate, that we're assuming is occurring normally. So you don't have a proximal RTA. What you have here is a necessity to do something about the protons that are coming in. And again, it's the function of the kidney to prevent the bicarbonate from falling. There's a caveat in that not all foods create protons. It depends on the type of food, and dietitians and others have broken up food that we ingest into whether it's proton forming, acid producing on the left versus bicarbonate forming on the right. So whether you have a diet that produces protons or not, in a net sense, depends solely on the content of what you eat. And there's large discussions about that, whether we have too much of a proton load in North America, whether we're constantly titrating the calcium from our bones, especially people with kidneys that can't deal with this, which we'll talk about in a minute, how the kidney deals with this. So we have this other process. Not only do we have to reclaim the filtered load of bicarbonate, when we don't, we either call that proximal RTA if it's in isolation. There are many mechanisms for that, which we'll discuss in later talks, or you have more global problems with the proximal tubule, which we call Fanconi syndrome. Problems with matching the daily hepatic proton load are not called proximal RTA, and we'll talk about that in a minute. So how does the kidney handle this problem? What does the kidney do about this proton load? So we have this problem. We have protons coming in around 50 milliequivalents a day. Well, it turns out the kidney actually generates, in addition to the bicarbonate that it reclaims, it actually generates a de novo additional bicarbonate above what it reclaimed from the glomerular filtrate. And it's not clear how it knows how much to generate, but as far as the amount, it matches the daily hepatic proton load approximately. And we don't have good ways of measuring either of these things. That's why I say approximately. No one knows for sure how close it is to the production rate. We have estimates of the hepatic proton production and estimates of the bicarbonate generation, but we don't know the exact numbers. But because the bicarbonate doesn't change in the steady state, we a priori assume that these must be essentially equal. So it's controversial in how to think about it, because some people say, well, the kidney gets rid of protons. That's how this is occurring. But in fact, that's not true. The kidney is a bicarbonate generating organ. That's how it's actually getting rid of now it does get rid of protons, but the amount of protons that it gets rid of that are free in solution in the urine are trivial. It's not milliequivalents per liter. When the urine pH is, let's say 6, that's 1,000 nanoequivalents per liter. It's like 10 micromoles or something. So that's nothing compared. The kidney would have to get rid of 50 millimoles or milliequivalents. Now, some people you'll see, and I'm sure you've been taught, the kidney gets rid of ammonia and that's how the protons are gotten rid of. That's not true either. And we'll talk about that. The kidney is responsible for generating new bicarbonate to match this daily hepatic proton load. Unfortunately, you'll hear attendings and others continually talk about ammonia excretion being how the kidney maintains this balance, or even some people just say proton excretion, both of which are not physiologically or biochemically correct. And we'll get into that because it's confusing. So we have this system where protons come in, kidney generates the sufficient amount of new bicarbonate if it's functioning normally, and carbon dioxide is made. Now, there are diseases that affect the kidney's ability to make new bicarbonate, and we end up with a metabolic acidosis. And one that you'll be very familiar with is CKD or ESRD. The reason you get a metabolic acidosis in CKD and ESRD is one reason only. It has nothing to do with anything other than the fact that the kidney is unable to generate sufficient new bicarbonate to match the daily hepatic proton load. If someone asks you, why does this patient have metabolic acidosis when they have CKD, your answer should be the kidney cannot generate sufficient new bicarbonate to match the protons produced from the patient's diet. So then the next obvious question is, how does the kidney generate new bicarbonate? And again, it's the proximal tubule in part, but not only. And it does so from this amino acid that I'm sure you've heard of called glutamine. And glutamine comes in across transporters on the apical membrane. There are also basolateral transporters too, but mainly apical. And the kidney converts the glutamine into something called alpha-ketoglutarate. This is a mitochondrial process. It's a two-step reaction that requires two enzymes. And the alpha-ketoglutarate in the Krebs cycle, which it enters, or in gluconeogenesis, generates two bicarbonate ions. chemically, it comes from the 2 carboxyl groups that are on alpha-ketoglutarate. And we know empirically, anything with a carboxyl group, when it's metabolized, generates bicarbonate. That's why we use lactate in PD solutions. That's why we use acetate in TPN. That's why we use citrate, Scholl solution to treat certain forms of metabolic acidosis. In all those, it's the same concept. There are carboxyl groups on these organic anions that, when they're metabolized, generate bicarbonate. So the bicarbonate that the kidney generates comes from alpha-ketoglutarate. The bicarbonate then leaves across the basolateral membrane of the cell on that same transporter called NBCE1A. But there's something else that happens in these 2 reactions in the mitochondria. As a byproduct of creating alpha-ketoglutarate, we also make 2 ammonium ions. Now, it's not NH3 that's made, it's already NH4 plus, just because of the pHs of what we're talking about. Now, that production of ammonium can't be ignored because of this important concept that if the ammonia derived from glutamine were transferred to the renal vein with the bicarbonate produced from alpha-ketoglutarate, bicarbonate would be consumed in the urea cycle and would not be free to match the daily hepatic proton load. Because if you think of what the urea cycle is, or another way of thinking about it, how do we make urea? Well, you remember maybe from medical school this complex system of enzymes, but if you look at just the compounds that come into it and simplify it as far as what's going into it and what's made, urea comes from 2 ammonium ions and 2 bicarbonate ions. That's how it's made. And so if all the bicarbonate that the proximal tubule created and all the ammonium that it created, and they're equal as far as amounts, went into the renal vein, they would just go to the liver and you'd make urea, and you would not do anything other than convert glutamine, which came into the proximal tubule cell, into urea. You would have done nothing for acid-base purposes. The whole idea of having alpha-ketoglutarate be metabolized to bicarbonate is you need it to match this other problem that we have from our diet, where we have basically a hydrochloric and sulfuric acid drip coming into our hepatic vein every day from the amino acids that we ingest. So we would just be converting glutamine into urea. It would be a futile cycle. We get rid of the urea. That's fine. We're getting rid of some, nitrogen, which is the purpose of excreting urea, so that the nitrogen that's in our amino acids from our diet gets out of the body in the form of this compound called urea. So we stay in what's called nitrogen balance, but we would have done nothing for acid-base balance. So the kidney then doesn't do that. The kidney does not send all the ammonium that was created as a byproduct in that proximal tubule mitochondrial reaction into the renal vein. In fact, it sends part. In fact, the majority of the ammonium it makes into the urine. So it brings up the concept that we call ammonium partitioning. All the bicarbonate that's generated from alpha-ketoglutarate is sent across the basolateral membrane and ultimately to the renal vein. But the ammonium that's produced in the cell is partitioned between the urine and the renal vein. And it turns out, if you do people did these kind of studies in the early 60s in humans, and found that if they cannulate the renal vein and the urine to get the total, about 40% of the ammonium that's made is sent to the renal vein and 60% to the urine. This is a normal person. Now, how it gets from the proximal tubule to the final urine is a separate lecture. There's a number of complex transport processes within the nephron that allow the ammonium that's made in the mitochondria from the proximal tubule to ultimately, the 60% of it roughly, to ultimately end up in the urine. The final step is that NH3 from the interstitium, that NH3 came from that NH4 plus. We won't talk about how it got into the interstitium and where in the interstitium, but ultimately it has to get into the collecting duct. And it's thought to do so on these RH proteins that you're familiar with in the red blood cell. But they're also present in the collecting duct and they are now known to be ammonia transporters. So the NH3 gets into the collecting duct lumen through RHCG and RHBG. They're two different proteins. The proton gets in on a proton ATPase, and ultimately you make NH4 plus, which comes out in the urine. Now, the entry of NH3 into the lumen of the collecting duct here, the lumen being the center of this cylinder, is dependent, like all passive processes, on the NH3 gradient. This is not active transport. It'll only move from the interstitium into the center of the tubule if there's a concentration gradient. And that's the importance of the proton secretion. The proton that's secreted because of the pK of the NH3 NH4 reaction, which is 9.2 or something, any acidification here will immediately convert NH3 to NH4. But what that does is not just generate NH4, it keeps the NH3 concentration here low, and that maintains this concentration gradient for NH3 to continually enter. We see experiments of nature where this doesn't occur in certain forms of distal RTA, let's say where you have a proton secretory problem, which we'll talk about. You can't acidify the urine, and that's a problem because then you get less NH3 entering. And so what happens actually in distal RTA, which will be another lecture, is that the ammonia partitioning gets all messed up. You can't excrete 60% of the ammonium that you made in the urine anymore because you failed to be able to generate this NH3 concentration gradient across the collecting duct. And the ammonia has to leave. It has to get out from the kidney, and it ends up going into the renal vein. And we end up making more urea than we would and consuming more bicarbonate than we would. And that's actually the reason in distal RTA you get a metabolic acidosis. But we'll talk about that separately. Okay, so those are some of the phenomena that the kidney has to do to keep the bicarbonate constant. In some, it has to reclaim the glomerular filtrate load, that box of Arm & Hammer baking soda, which is proximal tubule, and it has to also generate new bicarbonate, which to a large extent comes from the proximal tubule and alpha-ketoglutarate. I did not talk now about the collecting duct and what it does as far as protonating phosphate and ammonia, but we'll do that separately. For now, you can just think of alpha-ketoglutarate as being the primary source of, or the majority of, new bicarbonate generation, but not the only. There are smaller factors that are involved. Okay, so with that now, in a little bit of time remaining, let's briefly go over how we assess acid-base diagnoses. And there are many ways to do this. This is one I find very useful. They all rely on knowing the relationship between, for each of the acid-base disorders, the change in bicarbonate to PCO2 from normality. The expected change of each has a known number. And unfortunately, through medical school and residency, we only tend to think that there's an acid-base rule for metabolic acidosis. Some people use the Winters formula. In fact, all 6 cardinal acid-base rules have a rule that you, as a renal fellow, you have to know. So you have to rid your mind that the Winters formula is the only thing that you have to know. In fact, the Winters formula is more complicated. I'll show you something that's easier. But the concept is, to diagnose an acid-base disorder clinically, you need to know 6 rules. So here they are, if you haven't heard of them. One of them is actually recently more controversial, which we haven't decided on yet in the acid-base community, whether it's true or not, but we'll mention that just as a caveat. So in metabolic acidosis, all of you know that the bicarbonate decreases to variable extents, depending on how much protons were put into the system or how much bicarbonate was lost from the system, but the bicarbonate drops. We know that that's not the only thing that occurs from medical school, in that you have excessive ventilation that occurs with that, that drops your PCO2 because you've created a discrepancy now between the production and excretion of carbon dioxide. And it's known that the ratio of change in each is about 1-to-1 or 1.2-to-1. So if the bicarbonate, let's say, falls from 25 to 15 and the PCO2 started at 40, you'd expect about a 10 numerical fall. Obviously, the units are different. The PCO2 is in millimeters of mercury and the bicarbonate is in millimolar, but the absolute change should be numerically should be roughly the same, maybe a little more for bicarbonate. Again, you're assuming what the normality is. And what I just gave you are male numbers. If it's a female and you don't know her original numbers, you have to assume the PCO2 is around 38 and the bicarbonate's around 23, and then you see what the change is from each. And people don't do that. But if you're looking for subtle disorders, it's best to remember that, and even better to know what the numbers were prior to the current problem. Always compare things like anion gap or whatever it is, potassium, sodium, always know what the patient had before rather than assume that they had these population means that you memorize in medical school. Now, in acute respiratory alkalosis, that's another reason for a fall in bicarbonate. So what's shown here is all the acid-base reasons for a decrease in bicarbonate. And when you first look at the numbers, it's helpful just to look at the bicarbonate on the blood gases, which is calculated, or look at the total CO2 from your chemistry panel and say, are they normal or decreased or increased? If they're decreased, and again, you can look at the bicarbonate on the blood gas or look at the total CO2. They usually are very little different from each other, other than in certain circumstances, which I talked about somewhat. So here we're dealing with a drop in bicarbonate or a drop in total CO2. The second reason is acute respiratory alkalosis. That's also a situation where the bicarbonate's decreased. So again, it's not only decreased, there's three reasons why it's decreased, not just metabolic acidosis like everyone thinks of. And again, the PCO2 will be down. So you have these three acid-base disorders, the direction's the same for both numbers. The bicarbonate and the PCO2 are both decreased. The only thing that distinguishes them is the magnitude of the change from normality for each of these numbers. Now you could say, well, won't the pH be different? The problem is, if you start looking at pH, it'll help you often to distinguish, but sometimes it won't, because you'll have mixed disorders. And looking at the pH as a way of distinguishing these things is not a good idea. And you should stop doing it if you're already doing it, because you'll miss one important thing. You'll miss the ability often to diagnose mixed acid-base disorders. So it's far better to ignore the pH. Just rub it out from your mind. Don't look at it. The change from normality of each of these numbers will give you all the information you need. So in acute respiratory alkalosis, the change of each from normality is roughly 2 to 10 or 1 to 5, however you want to think about it. With chronic respiratory alkalosis, the PCO2 is the same, but the bicarbonate falls even further. And we'll talk about why these things occur. But the ratio from normality is not the same. And we used to say that it was about 0.3 or 0.33 or 3.3 to 10. But now there's some data from Nick Medias from a few years ago saying it actually might be 0.5 or 5 to 10. There might be a difference from what we taught before, and that's still not clear what the truth is. So for now, just make the diagnosis when it's about a third or 0.35 to 10. Conversely, the bicarbonate could be increased. And again, we have a rule for each. In metabolic alkalosis, we have an increase in bicarbonate, but if we look at the PCO2, it's not going to stay at 40. It actually increases, just same concept as in metabolic acidosis. In metabolic acidosis and alkalosis, we call the PCO2 change a compensation. We don't use the word compensation in the respiratory acid-base disorders. We just divide it temporally into acute or chronic. There's no rationale for that. We could call it compensated or not compensated, acute not compensated, and chronic compensated. It didn't evolve that way. So, and we never use the word primary or secondary either. Rid that from your mind. So as a renal fellow, stop saying primary or secondary. We just say there's a metabolic alkalosis, or there's an acute respiratory acidosis. And we don't say if it's a mixed disorder, which came first, unless you know from the chart. You just know that both numbers are there simultaneously, and we'll talk about that. So for metabolic alkalosis, the PCO2 goes up. It doesn't go up quite as much as it fell relative to the bicarbonate fall in metabolic acidosis. So for example, if I start to vomit and my bicarbonate goes from 25 to 35, my PCO2 will go up roughly from 40 to 47 if I'm normal. And that's not called respiratory acidosis or secondary respiratory acidosis. It's called normal compensation. That's what you should be inferring from the numbers. And the reason for saying that is if you're telling another human being that the compensation is normal, anything that's not that normal compensation then becomes a respiratory acid-base disorder. So for instance, in this metabolic alkalosis where you expect the PCO2 to be 47, if the bicarbonate increased to 35, if the PCO2 is 51 or 52, the patient has a respiratory acidosis. And if the PCO2 is 43 or 44, the patient has a respiratory alkalosis. Even though it's above 40, it should be 47. So the compensation in metabolic acidosis and alkalosis becomes your new norm. That's an important point. So don't say primary or secondary anymore, and don't use the word compensation when you're referring to the respiratory acid-base disorders. So another reason for having the bicarbonate increase is an acute respiratory acidosis, and there the ratio is very different. So for every 10 increase in the PCO2, the bicarbonate goes up about 1. And we'll talk about why it changes. It has nothing to do with organs in the body. That's just the bicarbonate buffer system equilibrium. It occurs when you bubble water with carbon dioxide to make Coca-Cola. Same thing, the bicarbonate goes up. And it'll change depending on what other buffers are there, but it has nothing to do with any organ physiology. But if we keep the PCO2 elevated and we keep watching it until a new steady state is reached, which takes about 3, 4, 5 days, we'll find the bicarbonate keeps increasing and increasing, even though the PCO2 is still, let's say, 10 above normal, and it'll reach a new, or sorry, it'll reach a new level to about 0.35. I'm sorry, in the previous one, I think I said 0.5 or 0.3 something. It's actually 10 to 5. The bicarbonate falls about half of what the PCO2 fell. In respiratory acidosis, there's controversy currently where we use about 0.33 or 0.35 or 3.3, 3.5 to 10. Some people think it's actually 5 to 10, just like the respiratory alkalosis. I'm sorry about that. Yeah. So these are the 6 cardinal acid-base rules that you need to memorize in order to interpret why the bicarbonate either increased or decreased. And if you can remember these and the patient fits one of these, then you know the patient has most likely that acid-base disorder. And if it fits, you also know that it's not a complex acid-base disorder. Now, let's say you do the numbers and it doesn't fit any of these. Well, you know the patient has a mixed disorder, because if it was a simple disorder, it must fit one of these. So I think I'll stop there, and we'll go on next week to discussing this concept that there's a continual relationship between bicarbonate and PCO2 that we artificially break up into the respiratory acid-base disorders. We'll review some of the other acid-base rules again that we just discussed, and then we'll go into the anion gap and the subtleties of that and other things. And ultimately, we'll start doing real-life patient questions once you've mastered these concepts. So I think I'll stop there and like to open it up to any questions people might have.